Welcome to the HTI-1 Final Rule Session Overview with Question and Answer. My name is Chiara Matrosino with Kaufman & Associates, and I will be assisting with the logistical support for this Zoom session. We will begin with approximately 15 to 20 minutes of presentation, followed by a question and answer session. To ask questions, click the Q&A button at the bottom of your screen. Or if you'd like to ask your question verbally, please use the raise hand function under reactions and we will unmute your line. However, please note that there are restrictions to what can be answered due to the Administrative Procedure Act. We ask that you select Speaker View option located at the top right side of your Zoom interface. This will allow you to see the speaker as they present. Finally, be aware that today's session is being recorded. Closed captioning is available by clicking the CC icon at the bottom of your screen. I will now turn it over to Kate Tipping.
Thank you. Welcome, everyone. Thank you for joining today. Today, we're just going to do a brief overview of the HTI-1 final rule and reserve most of the time for questions and answers. So again, my name is Kate Tipping. I'm the Deputy Director in the Regulatory and Policy Affairs Office and the Office of Policy at ONC. And I'm going to walk through generally what is included in the final rule. Again, we've recorded our previous webinars. We have a longer one on the overview. They're all recorded and you can access them by going to our website. Okay, next slide. So just to note a bit of a disclaimer that everything in this presentation, though we try to make it as accurate as possible, we refer to the document that was published in the Federal Register on January 9th, 2024, that amends parts 170 and 171 of the CFR. And again, this communication is produced and disseminated at the U.S. taxpayer expense. Next slide. So the purpose of the HTI-1 final rule, part of it was we're implementing still portions of the 21st Century Cures Act. So though we had a number of the conditions of maintenance of certification requirements included in our ONC Cures Act final rule, we did not include the EHR reporting program. And we also elaborated on the information blocking provisions that were included and the API provisions. We also put out this final rule to achieve the goals of the Biden-Harris administrative executive orders, including the one related to public health, 13994, advancing racial equity and support for underserved communities, and the safe, secure, and trustworthy development and use of artificial intelligence, as we'll discuss in our decision support interventions updated criterion. And also we're leveraging Health IT and advancing interoperability through the HITECH Act, interoperability advancement, and our ONC Health IT certification program. Next. So what's in this rule? We include a new regulatory approach for certification criteria. We're doing away with the what we had called additions of the certification criteria. We include certification standards and functionality updates. Like I mentioned, the decision support interventions and algorithmic transparency, a new insights condition and maintenance of certification requirements, which was referred to in the Cures Act as the EHR reporting program, and information blocking enhancements. Next slide. So the discontinuing year themed additions, as you know, we have in the past referred to our certification criteria as most recently the 2015 edition Cures update. Prior to that, the 2015 edition, 2014 edition, 2011, and it hasn't been keeping up with either the calendar year, or so we've decided to do away with the additions and make incremental updates to the certification criterion so they would all remain in one part, 173.15 of the CFR. And we would include dates by which the prior version of the criterion is no longer applicable when a revised version is adopted. We include in the standards the expiration dates for the adoption of when new or revised or updated versions of the standards are adopted. Next slide. And with that, we have two forms of compliance. So for the update and provide, when the health IT developers have a health IT module certified to any of the revised criterion, when they must update and provide such update to their customers, we include language in the OMC certification criteria in section 173.15. We also include in the assurances condition a condition that the developer must provide an assurance that it will not interfere with the customer's timely access to interoperable health IT certified under the program. So they must provide the revised or updated certification criteria or standard. And then also in the maintenance of certification, we include specific language that the health IT developer must update the health IT module once it's certified to section 173.15, including the most recently adopted capabilities and standard included in that criterion. And then the developers must provide all health IT modules certified to a revised criterion to its customers. We did, compare to the proposed rule, we did update the timeliness requirements. We tried to eliminate some of the confusion based on 24 months, but instead just referred to the timeline that's included in the certification criterion or the standard. Next slide. So I'm not going to go into detail, but these are the revised standards and certification criteria that are included in the final rule. I'll mention a few. The United States Core Data for Interoperability. We updated the version 3 for USCDI will be the new baseline. And then also we've updated the electronic case reporting. It requires health IT modules to support the electronic case reporting criterion using consensus-based standards. And then also we had included in the proposed rule a criterion related to patient requested restrictions. And then in the final rule, we didn't finalize that criterion specifically, but we made adjustments to the view, download, and transmit criterion, where we noted that an internet-based method for patients to request a restriction on the use or disclosure of their data in that criterion. Next slide. Okay, so this is the DSI portion, and we did have a webinar on this so you can get more specifics, but basically how can the AI be used in healthcare? And you can see a number of ways: monitoring the patients, predicting health trajectories, optimizing operational processes, but there are some challenges noted here. Next slide. So in the final rule, what we did, we revised our existing clinical decision support certification criterion by building on existing capabilities. We provided a definition for the predictive decision support intervention, included requirements for health IT modules to enable the users to provide electronic feedback data for the evidence-based DSIs and export such feedback. We select both evidence-based and predictive DSIs, access complete and up-to-date source attribute information, and record change in access source attributes for the evidence-based and predictive DSIs. We also established a new assurance maintenance of certification requirement to review and update the information on an ongoing basis. Next slide. So the impact of the new decision support certification criterion, we note that it would improve transparency, enhance the trustworthiness and the risks, and eliminate some of the potential risks, and govern how predictive DSIs are supplied by the health IT developer as part of its health IT module. It would also foster an information ecosystem and advance health equity by design. Next slide. And next week, we're going to have a webinar on the insights condition, but I'll mention a few points here. So basically, the insights condition, it was noted in the Cures Act as the EHR reporting program, and the Cures Act basically laid the foundation. It established the requirement to create the electronic health reporting program, to provide transparent reporting to measure the performance of certified health IT, and it specified its implementation as part of the condition and maintenance of certification for developers of certified health IT. And the goal of the insights condition is basically to be transparent, provide transparent reporting that would address information gaps in the marketplace, provide insights on the use of specific certified health IT functionalities, and provide information about the consumer's experience with the health IT. Next slide. So these are the measures that we included in the insights condition and what the related criterion or criteria is in the ONC certification program. Next slide. So basically, who will be reporting on these measures? The developers of certified health IT must submit the responses if the developer meets the following criteria. It has at least 50 hospital sites or 500 individual clinician users across their certified health IT, has any health IT certified to the certification criteria specified in each measure, and has any users using the certified health IT associated with the measure. The developers that don't meet the qualifications will submit an attestation indicating that they don't meet the minimum reporting qualifications. Next slide. And then what is the reporting timeline? So for each of the measures, we have identified in which year the program will begin collecting the data and which year the reporting must be done. So on this slide here, you see the different measures and the year in which the collection will begin. Next slide. And this is just an overview of what the reporting timeline is for the insights condition. Basically going through years 1 through 4 and with which data collection is required for which year measures. Next slide. And again, the insights condition, we're going to have a deep dive into that next week. But that was just a quick overview. So a quick overview of the information blocking enhancements that are included in HTI-1. We've went through a number of definitions and made clarifications or enhancements for the information blocking definition, business associate, health ID developer of certified health IT, and the offer health IT definitions. In the exceptions, we made some revisions and made some additions to the exceptions. So in the infeasibility exception, we revised one of the conditions and made 2 new conditions. So the uncontrollable events condition, we provided a clarification when an actor's practice meets the uncontrollable events condition. And then the 2 new ones is the third party seeking modification use and the manner exception exhausted. And in the manner exception, we basically, because we provided the date for the content of which the actors had to comply with was October 6, 2022. But since that date has passed, the final rule revised that exception to remove the content condition as it's no longer necessary. And then the new exception that we provided is the trusted exchange framework and common agreement manner exception. And that is new. And I'll go over that briefly. Next slide. So for the new TEFCA manner exception, it applies where the actor and requester are both part of TEFCA. The access, exchange, or use of the requested EHI can be supported via TEFCA for both the actor and the requester. The request for access, exchange, or use is not via the API standards adopted under the program, and any fees charged and any licensing of interoperability elements by the actor in relation to fulfilling the request via TEFCA satisfy the fees exception and the licensing exception. Next slide. And then this is just the key dates. We tried to provide an overview of all of the key dates of the updates to the ONC Health IT certification program. And this is just a screenshot of those key dates. And we have this available as a resource on our website as well. Next slide. And again, these are just other resources available on our website. We have the fact sheets. And then we do have for the insights condition, we have measure spec sheets for each of the measures within the insights condition. And you will hear more about that next week. Next slide. And like I said, the insights condition is next week, February 8th at 3 p.m. So please register for that. And that is just a quick overview. Like I said, mainly we're going to focus on questions and answers today. So I'm going to pass it over to my colleague and we can start answering some of those questions. Beth, can I pass it on to you? I don't know if we have any folks that want to raise their hand.
Yeah, let's start with that. And I know that some of our team has already been responding to some of the questions that are in the Q&A queue. So I'm going to ad lib for 30 seconds or so while we wait to see if anyone wants to raise their hand to be unmuted to ask a question out loud. In the meantime, if anyone on our teams wants to address either a question that was asked or a question that is has already been answered, but you want to say out loud because there have been several similar questions, then I think we can go ahead and do that while we're waiting. And actually, there was a question that was about standards and expiration, and I answered it, but I'd actually like to call on Matt Ron. Do you want to quickly just explain in a sort of general sense, our process for updating standards in the reg and how that relates to SVAP? I think it can be a pretty high level, but it might be useful for folks to hear.
Yeah, can you hear me, Beth?
Yes, I can. Thanks, Matt.
Can you point out the specific question? I didn't see it.
Sure, so the specific question, oops, I'm echoing. Thanks. So the specific question was, does the expiration date also apply if a standard is currently adopted only via SVAP and not formal regulation? And I wrote back explaining about how expiration dates are applied to the standard and the relationship sometimes between what we SVAP and what we adopt in future reg, but it might be beneficial for you. As for those who don't know, Matt is the director of our division for standards, to sort of do a quick overview about how we think about it and how they relate.
Yeah, so thanks, Beth. So on the SVAP, it generally in between regulation cycles, we'll say here, is like currently you could have your product could be updated to USCDI version 3 with US Core 5.0.1 and CCDA. Wait, I mixed it up. 6.1.0 and CCDA R4.1. And when this goes into effect at the end of 2025, so January 1st, 2026, you would have met that expectation already. But before this goes into effect, there could be an opportunity to move to a newer version via SVAP, but the baseline does get reset once January 1, 2026 comes into play. Is that answering the question, Beth? Sorry.
Yes, thank you. And I think that in general, it's just helpful to remind people that SVAP is sort of that voluntary space in between, as you mentioned, and then we will periodically update the standard version, and it may not always be the version that was SVAP. That's just the other thing to keep in mind. In the reg, we're trying to advance the baseline, and just based on timing of when the reg happens versus when standards versions are done via SVAP, it may be that we're advancing one step further than what was the last time. So hopefully that's helpful to folks who are just trying to sort of understand how these things interplay. And as Matt mentioned, there will be another cycle for SVAP coming up as well. Let me take a look and see if anyone has tagged a question to answer live. People are typing away and getting questions that way. Do we have any hands raised?
We
It looks
do.
like we have a few, so let's go to those. The first one I see is Michelle Knighton. Can we unmute Michelle?
Sure, I didn't realize my hand was raised. So sorry about that, but I do have an outstanding question in the Q&A, and I'm happy to say that out loud. So I had a pretty involved question about the definition of PDSI, and Jordan was kind enough to respond and say that it's not specific on machine learning approaches. And so the follow-up was, based on that response, does that mean we would need to research every single possible assessment we offer in our system to find out whether it was training data used to create that assessment? And if it was, every single one of those would qualify as PDSI. Am I thinking that through correctly?
I think generally that there will be some work to do to develop something like what's often referred to as a model inventory to identify the cases in which predictive decision support are used in your product, and those would apply. I don't know enough about the technical specifics to say if that applies to every assessment, but generally likely to be some work to develop an inventory. Yeah.
Okay, and so like the key though is that it is based on training data.
Right, with the the caveat that there are parallel but separate requirements for evidence-based decision support in B11.
Sure. Yep, absolutely. Great. Thank you so much.
And I'd also say that the definition, has three components. It's based on training data, produces an output that's used in decision making, and so considering each piece of the definition in making a determination will be useful.
Absolutely. Thank you.
If we can go to Daniel Tam.
Yeah, hi there. And Beth, I saw you answered my part of my question, but I had a follow-up. It's related to that 1 hour revocation ruling.
Yeah.
I just wanted to clarify. So I work for a primary care clinic, so we're only open during business hours, like 8 to 5. And we're not open in the evenings and generally on the weekends. And so I just wanted to double check if a patient wrote into our email system or our call center asking to revoke access, we're not going to see that until like until the next day or until Monday morning if they wrote in on the weekend. And I just want to clarify, are we still compliant with that 1 hour ruling as long as we can get to that once we see that request from them? I just want to understand if we're compliant or not, or recommendations you have for people in my situation.
So it's not you that needs to be compliant, it's your technology system. So it may be that that's where we need to figure out where the detail level is. So the answer would generally be no. And part of the reason for this is that if there's a revocation, one understands that may be indicative of a privacy event, right? For example, a patient has their identity stolen, and they know that there has been bad acting or some sort of issue with an app that may be accessing or an individual that may be behaving and using that app or identity. So that's actually part of the reason that this is 1 hour, because for exactly that reason, if it was over a weekend, that's could be up to 64 hours that there isn't a response for an individual who knows that they are at risk from a privacy event. So that's the reason for it. I think the difference between what you're required to do and what your technology is required to support for you might be where the rubber hits the road on this. And I think I would actually need to snag some of our very detailed tech people to figure out if we can try and identify what that might look like. So if I can ask for you to shoot me a message, I will follow up on the question that I already answered for you and provide you with my email address. And you can shoot me a message and we can connect in with the technical expert who actually works on all of the revocation token standards, so we can pull them in.
Yeah, that'd be great. And the reason I'm bringing this up is in some cases, this is going to require like an engineer or developer to go into our systems and revoke that token. And I think this will be the case for other people. And so we can probably build stuff potentially like in our web application where a member could self-service, but let's pretend they lose their access to their our patient portal, like they lose their password and they can't even log in there. Then really the only way they can get in is to call in or to email in. And again, I think like me, other providers will be in a situation where they may not see this until business hours. So it was just something I wanted to bring up for your group to consider.
Yes. Yeah. So we will. I'll give you my email. Please follow up.
Cool.
We need to. We need to have a conversation because your tech needs to be capable of doing this. And actually, previously, I think we had a sort of 24-hour cycle on it. So there needs to be something in your tech that is allowing for an automated token revocation. So let's follow up and see what we can figure out to help.
That'd be great. Yeah. Will you just respond in that thread? And
yep. I'll put it right there.
Great.
Yep.
Thank you so much.
So in the meantime, if we can go, I'll do that in just a second. I'm going to go to Andrea Benari. I apologize if I am pronouncing your name incorrectly.
Oh, no, that's fantastic. Thank you so much.
Okay.
I have a question over here about the activation of the DSI rule, especially when it comes to AI vendors that are independent of an EHR. So I'm new to the Health IT certification program, and my current understanding is that it typically applies to EHR vendors. But what the ONC has done right now with DSI is fantastic because it can bring a bit more transparency to the AI vendors themselves and clean up the Wild West we typically see in deployments. And I wonder whether there's a path for AI vendors to just get certified to the DSI criteria alone. And the EHR would fulfill all the other health IT criteria. Does that make sense in terms of where I'm going with the question?
Yeah, and it's an interesting question. This may be another one that I actually want to tag some of our certification team to do a follow-up, but the sort of general response is if the AI vendor and their software functionality is capable of meeting the requirements of the criterion, there is no restriction in them getting certified. And technically speaking, you'll see this throughout the reg, we say health IT, not EHR. And it's a very, very broad definition for exactly this reason. There might be instances where, especially if you have a platform that can connect into an EHR and that you are providing decision support interventions or, decision support interventions and quality services, we actually know of a couple interesting dashboards that are linking things together. And that is including DSI in particular, and you're sort of providing that whole package service. There isn't necessarily a reason that you couldn't be certified. So I think it's worth taking a look at the requirements and seeing if it is something that that your technology would be capable of doing, because then you have the option of working through certification on your own and being able to offer that to your customers as well. It's worth checking.
Exactly. The one hiccup that I'd love to discuss offline is the activation requirement, because I think that one is a bit more bespoke and might be contingent on the HR. But thank you. I would love to have a follow-up on this one.
Sure, but when you do and we have a follow-up on it, you should talk with us about relied upon software. If you have a known product that you use regularly, and that would be doing the activation portion of it, there may be ways that you can identify how that would work and what that interplay is in order to work through certification. We have done this type of there are scenarios like this already. The one thing's about sometimes patient portals are an entirely separate product. And there are ways that you are identifying the scope of how you're meeting the requirements using something called relied upon software, which would identify the actual capabilities. So for you also, I will put a message in the chat to reply or shoot me an email, and we will follow up.
Perfect. Thank you so much.
Beth Anofri, I apologize if I got your name wrong, Beth. If you can be unmuted and go ahead and ask your question.
I don't know that I asked my question or had a question. Did I raise my hand? Oh, I did. Apologize. I do not have one at this time.
Okay, thank you. Daniel Nikita, is that correct?
Hi, yes, Nikita, Daniel Nikita, thank you. Yeah, I got a couple of questions about the DSI certification there. So I understand that is going to be B11. How does that relate to the current A9 CDS certification? Is that going to supersede it? Is A9 going to stay in place? And is that going to be handling non-predictive, non-AI CDS? So that's my first question. And then somebody already asked in the chat if this B11 is or DSI is an attestation and what kind of information we need to provide to support it. Maybe you can clarify that. The answer was that it's not an attestation, but there are specific requirements applicable to developers. But again, what will be required there? Because there was quite a bit of sort of supporting information that was presented in the webinar related to this. So
sure. So I'll start with the first one and then I'll pass it to Jordan. The very, very short answer on A9 is A9 is expiring. It has an up to and including date on it. So instead of saying expiring, we expire standards. And then for criteria, when they are being removed from the program, we say that certification is available up to and including X date, and then it's no longer available after that date. So that is what's happening with A9 and the B11 relationship. Jordan, did you want to talk about the rest? Thanks.
Yeah, so I think I may have misinterpreted the question in Q&A where in the proposed rule, there is a component within the B11 criterion where folks attested to whether or not they enabled or interfaced with the predictive decision support intervention. And that's no longer in the final rule, that's not included. And so I had on my mind that attestation. However, in terms of the criterion itself in a test procedure, there B11 will be attestation to certify rather than a specific test procedure. So I hope that clarifies.
Yeah, okay, it does. And I don't know what the ACBs will require for us to demonstrate its, the FAVES framework and all of that. Like how much are we gonna have to supply to, sort of reassure the ACBs that this is a high quality AI and what kind of evidence and how does that play out again, evidence if it's trained on proprietary data, how any further insights on that?
So for that one, I would say you're going to want to check with the ACB itself. They are very, very good at providing guidance on what they're looking for and the types of questions that they might have. So it's really good to have a conversation with them about what your unique circumstances are. Any guidance we give wouldn't be specific to your unique circumstances. So that is a really, really good conversation to have with them because they'll be able to tell you, here's what we would want to know, here's what we're looking to see, and they'll work with you to be able to do that.
One thing I will say, generally speaking, is that the construction of B11 is to enable, transparency into these predictive decision support interventions. ONC and the ACB wouldn't be specifically evaluating whether or not an algorithm is fair, appropriate, valid, effective, or safe as part of that. That's not the objective of the rule. It's to aim for transparency and to allow others to make that determination kind of in the market.
But the ACB may have a requirement where they say, well, we do want to see something that demonstrates this. Would they? Could they? That demonstrates faith, you know, that it is fair, appropriate, valid, effective, and safe.
Yeah, I guess we won't maybe go into that level of detail, but would just say that they won't look at, you know, a specific threshold. So they may ask for documentation, but they won't evaluate, you know, this is over the bar or under the bar.
I see. Okay. All right. Thank you for that. That was very helpful. And just again to clarify, so B11 will supersede A9. A9 is going away. B11 is going to be the new CDS certification.
That's right. And it kind of contains an evidence-based component and a predictive component. The evidence-based being a very straightforward kind of outgrowth from A9, I think.
Yeah. Okay. Thank you.
So there's one that is in the Q&A queue that I'm going to take really quickly before we go to Matthew Davis, whose hand is up, because I think that this is just a really important point, and we've gotten a couple questions about sort of expiration dates and the certification criteria and how they relate to each other and what that's all what that all looks like. So the question is, prior to 2025, we are using ONC 2015 edition, Cures edition, now moving to SCDI 3. Does compliance and attestation automatically meet the new criteria, or do we need to do testing and certification? So the process that we've established, and hopefully this becomes much more clear going forward as we continue to do it this way. So the way we're doing it for the standards expiration dates, and then for the criteria for up to what time you can be certified to that criterion, and we're doing concrete dates for each of those things, essentially based on feedback from the public, and in particular feedback from developers, that they want to have the option of moving to the new criteria sooner rather than later. They don't want it to be a specific cutoff date, do one, then switch to the other, no matter what. They want to be able to work ahead. But also that if there's a standards update, but the criterion isn't changing, that realistically, there shouldn't be a requirement to go back and certify to the exact same thing with a modified data element for USCDI. So the answer to this particular question, I'm going to type it out as well, but the answer to this particular question from the point of view of USCDI version 3 is it is very much going to depend on if the criterion is also being updated or if just the standard is being updated. So if the standard is being updated, but the criterion itself is basically staying the same, that would be the compliance via attestation and doing your, doing the updates regularly that you do with the ACB of what standards you're on. And then the criterion might be updated in some cases. For instance, if it's capturing a different data element because there's a new set in USCDI and using that for a specific purpose, or if there are other updates in the criterion themselves, then it's not a recertification or something like that. It's actually that you have certification for the existing criterion. What you need to do is certify to the new criterion. In some cases, those might be attestation, like some of the F suite are still attestation. In other cases, it's certification via testing. And for developers who are wanting more detail than I am providing, I have been told by the certification and testing team and the certification program folks that they are going to be doing a whole host of program webinars for developers, and the roundtable site setup that they do for developers, as well as their listserv and the actual updates to testing that will be available on our website for all of those test criteria and CCGs and things like that, that will coincide more closely with the actual effective date of the rule. So hopefully that's helpful, and I'm going to stop there and see if Matthew Davis wants to come off mute and ask a question. Matthew Davis.
There we go. I didn't have an unmute button at the time. Can you hear me?
Yes.
All right. So I have 3 mentions at the moment. First of all, I want to thank Matt Ryan for the clarification regarding bulk data and the IG not changing. It was kind of touched on in the final rule, but I wasn't completely sure. So he clarified that. It will remain on version 1.0.1 or 1.0.1. Okay. One quick yes or no. DSI is an attestation. Is that correct?
Yes, it is an attestation.
Okay, and then my last one is more so about the time frame for the test steps and the companion guide documents. Those are insanely helpful. Do we have any deadline or any expectation of when those particular documents will be available for HTI-1?
I'm sorry, so you're asking about the CCG documents and things like that?
Oh, no, sorry. So I said companion guide, but I meant the testing guide, the
Oh, right.
CCG.
Yeah. The testing guides. So that's what I was
Yes.
just saying. They're in development, and we are hoping to release them very, very soon. In sort of, the effective date is always a little bit delayed from the end of the rule, so we're hoping to release those very, very soon. The program team is working on it.
That's great. Yeah, because those are really helpful. And I think they will. So as wonderful as the final rule is, I think meetings like this, and I think those specific documents will give implementers a clear-cut understanding of what they need to do and what they need to meet. Thank you.
Thank you. I'm going to go to Cassie Weaver, who has tagged one of the questions in the queue to answer live, and then I will circle back to those who have raised hands.
Thanks so much, Beth. I'm going to answer a question about providing additional guidance or direction on how the new TEFCA exception will impact specifically healthcare providers, and a quick explanation of what TEFCA is. So TEFCA is a ongoing process that ONC is helping to lead that will form sort of a nationwide network of networks that will allow the secure exchange of EHI between what are known as QHINs, or Qualified Health Information Networks, and their participant and sub-participants who are parts of that QHIN. And the TEFCA exception is designed to allow entities who participate in TEFCA to use TEFCA-based manners of exchange when they receive requests from other entities who are also part of TEFCA. And as part of that exception, both entities do have to be in TEFCA as a QHIN participant or sub-participant, and the requester has to be able to actually receive the EHI and be able to use it in the manner that they requested, even if they're receiving it in this different manner through TEFCA. And we also have an exclusion for requests made via FHIR API, in that if that's what a requester asks for, then providing it via other TEFCA manners would not fulfill this exception. So in considering how it would impact healthcare providers, the question would be if they are in a QHIN as a participant or a sub-participant, and whether they are receiving the request or making the request. But just to provide some reassurance, do remember that the requester does in fact have to be technically able to access, exchange, or use the EHI that they have received. So if they aren't able to, then again, this exception would not be available. I hope that helps. And there is lots of information on our website about TEFCA. And I really encourage folks to go and read it and check it out. It's lots of interesting stuff. So Beth, I'll hand it back to you now for the next question.
All right, great. So I see a hand up from Bob Bryan.
Hi, thanks, Beth. I have a question about the situation for developers once they're certified to B11. And they may or may not be providing or supplying DSIs, but they're fully certified to the rule. And then there comes a time when they do decide to supply an to supply particularly a predictive DSI. And they need to meet the conditional requirement related to risk management. And then my question is kind of two things with respect to what they need to do with source attributes in terms of looking at the DSI that they're choosing to supply. Do they need to confirm basically that all those source attributes can be populated by the DSI? And then secondly, in this scenario, they're already certified. What will they be doing in relation to their ACB and ONC to do an update or anything at this point in time when they choose to supply a new predictive DSI?
So I think there's a lot there. Jordan, did you want to try and unpack some of that, and we can try and get through some answers?
Yeah, agreed. There's a lot there. I think, the fundamental requirement is to keep up to date information on source attributes that the developer of certified health IT supplies as part of its health IT module. So at the point in time when they do decide to supply that predictive decision support interventions, it would be expected to be accompanied by the required source attributes, and not if the developer of certified health IT is supplying it, that those source attributes would need to be populated with information. Does that start to answer?
Yes, it does. And the second part of my question is kind of more from a regulatory perspective. Is there anything that the certified developer will need to do in relation to their ACB when they make that decision to supply a new DSI after they've already been certified?
I think that's one we'll take back to the certification and testing team and make sure as we move towards the resource guide, that's clear.
Okay, thank you.
Okay, so I am doing a quick time check, and it looks like we have a little bit more time. So I am going to go to, I don't see any hands raised. I'll give you, oh, I lied. Okay, Debbie McKay, off you go. Can we unmute Debbie McKay?
Thank you so much. I have a question about the situation where a health IT vendor may not be supplying predictive DSI from the beginning. They may add it in later. So that raises some questions about, I think we would have to provide still the way for clients to add their own record, change, and access the source attributes for DSI that they create or they select from another vendor. But beyond that, we have questions about if we aren't supplying it, there's also this summary document that we have to provide that explains our intervention risk management practices. Do we still need to have that done, even though we haven't implemented any predictive DSI yet? Or do we just say in that document we will provide the detail once we deliver or supply predictive DSI? And then the second question is kind of related. We have to do the safety enhanced design study, and if we have not delivered and we're not supplying predictive DSI, are we still expected to do the safety enhanced design study for predictive DSI? Or would we do that subsequently when we actually add something that's predictive DSI?
So the first question is I think more straightforward, where the regulatory text for B11 says intervention risk management practices must be applied for each predictive decision support intervention supplied by the health IT developer as part of its health IT module. So in the case where you don't supply any predictive decision support interventions as part of the health IT module, there'll be no intervention risk management to do. So that
Right, but we still have, there's that ONC, the ONC ACB provision that they have to collect from us, a summary document about our risk management practices. So that we have to give them a hyperlink to that. So would we just be able to say there that we haven't yet supplied predictive DSI and we'll update the document once we have?
I think something like that would be appropriate, yeah, but
Okay.
no work within it.
Perfect.
For the safety enhanced design part, I would say to reach out to me or to the certification team, and we'll respond.
And is this Jordan? Can
Yeah.
you maybe ping? Do you want me to put something in so I can get your contact information?
Sure.
Okay, and while we're going that direction, I have a Mike Lipinski would like to answer this question live note. So I will turn to Mike. Do you want to go through what your question is?
Sure, Beth. Yeah, and in I think it's from Janice Karen. Says if an actor has a delegate in QHIN, is the delegate on the hook for information blocking or just the principal? So a lot of terms there. Not sure what Janice meant by some of them, so we can open up to her to clarify. But QHIN is Qualified Health Information Network. They are selected to be part of TEFCA by the Recognized Coordinating Entity, RCE. So an actor is one of 3 types of regulated entities under information blocking. Subject to information blocking is another way we discuss it or refer to it. So there are healthcare providers. There's a definition for that. There are health IT developers of certified health IT, which include offerers of certified health IT. And then there are health information networks. And that's a functional definition. So a provider can be that, a plan could meet that definition. Lots of different entities can meet that definition. It gets into whether you determine and control discretion over various agreements, terms of use of access exchange of use, or even the technology that's used for that. So again, I'm happy to have Janice try to clarify a bit when she talks about a delegate. So I don't know if she's talking about a business associate, which could be like a developer, or if she's talking about a different part of her healthcare system. But everybody, I just wanted to kind of be clear about who the actors were and what they were participating in here, which would be part of TEFCA. And TEFCA currently states, part of the common agreement and the flow down framework agreements is that you're still subject to all applicable laws. So if you are subject to information blocking, as I've described those entities, you'd still be subject to information blocking as part of a QHIN and part of TEFCA subsequently, obviously, if you're a QHIN. Don't know if that helps, but happy to stay on and answer more if there's any clarification to go along with that question. If not, we can move on.
Okay, I have one that is tagged that Cassie Weaver would like to answer live.
Thanks, Beth. The question I'm answering live is, can you review how the manner exception can be used and what standards would qualify to provide the requesters as part of the manner exception? And at what point are we able to use the infeasibility exception? I'm going to start at the end and say that the infeasibility exception is available at any time. There's no requirement to have tried out other exceptions first. There are a number of different conditions in the infeasibility exception that covers different situations. So you'd want to take a look at those conditions to see which one might fit. But in HTI-1 final rule, we did finalize sort of this manner exception exhausted condition, which does tie back to the original question. So the manner exception is used a couple different ways. So first, if an actor is responding to a request to access, exchange, or use EHI in any manner requested, then the actor and requester can come to whatever terms and agreement they would like in that negotiation, and they don't need to worry about satisfying the restrictions found in the fees and licensing exception. However, if the actor and requester are unable to come to an agreement, or if it is technically infeasible for the actor to provide the EHI in any manner requested, then they would move to the alternative manner condition of the manner exception, which lays out 3 different alternative manners that are to be used in a stepwise order, beginning with standards adopted under ONC's Health IT certification program as specified by the requester. And then through content and transport standards specified by the requester and published by the federal government or by another standards developing organization accredited by the US government. So ANSI is an example there. And finally, if that still would also be specified by the requester. And then finally, the third and final alternate manner is to use a machine readable format. So those are the standards that would qualify. Again, note that they have to be specified by the requester and that they should be used in that order, which is sort of descending from most to least interoperable. But ideally, a requester would be able to use one of those manners to access, exchange, or use the requested EHI. If the actor is providing the EHI in one of those alternative manners, then they are subject to the fees and licensing restrictions. And so you'd want to take a look at those exceptions to make sure that any negotiated fees or licensing terms do meet the restrictions found in those exceptions. If all of that doesn't answer the question and you want me to talk about the manner exception exhausted condition of the infeasibility exception, I can, but I'm hoping that that might be enough information for this so that we can get a few more questions in.
Okay, so I see, since no one piped in for more on that particular one, but we'll keep an eye on the chat for additional updates. I see 2 hands are raised. They are both from people who already had questions, so I am not sure if they are new hands or old hands, but I'm gonna circle to make sure that none of the team has tagged anything that is someone who hadn't gotten a chance to ask a question yet that we wanted to address or answer, because there are quite a few in the open queue and we only have a couple minutes left. So anyone on ONC team have a particular one in the queue that you would like to answer out loud? Okay, then I'm going to circle back to the hands that are raised. Debbie McKay, your hand is up.
I already asked my questions, so my apologies. I didn't, if I put my hand
Okay,
up.
no problem. Janice Karen, your hand is up.
Hi, yes, this is Janice Karen from the Massachusetts Health Data Consortium. I just wanted to follow up because delegates and principals actually do have a very specific meaning in TEFCA. The TEFCA Common Agreement version 2, which is currently out for comment in draft and it's supposedly being finalized by the end of March, introduces these new concepts. And a delegate is someone who acts on behalf of someone else within the TEFCA system, so on behalf of a principal. So if the delegate is not the person who's the original source of the information, but they are the ones who are interacting with TEFCA for the information. And so since we were talking about how TEFCA and the information blocking rules interacted, I was curious if there had been any consideration of that role yet, but certainly obviously not from the person who answered the question yet, since they weren't up on the new stuff yet. But if anyone else has, that would be fantastic.
Hey, this is Mike. Yeah, I can answer that still. The delegate is, yeah, it's just a terminology for TEFCA that doesn't change whether you are an actor under our rules, the information blocking rules. And to give you a good example, there are business associates of covered entities that aren't covered by our rule. Some that do release of information, but they're a business associate, but they wouldn't ultimately be subject to the information blocking rule because they're not an actor. That's why I spent some time talking about the 3 types of actors that are covered. So the healthcare provider would be the one. If it was a healthcare provider delegated somebody else to be their representative under this agreement or other agreements, then they would still ultimately be the one subject to information blocking. Similarly, if a principal wasn't one of our actors under the information blocking regs, didn't meet the QHIN definition, didn't meet the healthcare provider definition, or didn't meet the offer of certified health IT, which is encompassed in the developer certified health IT definition, then they wouldn't be covered. So sometimes it's not super complicated when you just go back to, are you an actor under the rule, right? And then the actor is subject to, for whatever actions it takes and agreements it sets up on its behalf. It just would be the same as if you had an authorized representative who signed an attestation form under our program for a certification program. It's ultimately going to come back to the actor that's subject to the regulations. I hope that helps and clarifies. And I appreciate you following up with your further question.
So we are at time. I want to thank everyone for joining us. I will note that some of us are in the middle of typing a few more answers. So if you hang on for one more minute in a little bit of silence, I realize that's awkward, but a couple more answers are coming through, and hopefully those will get closed up. At least a couple more questions, and we'll just take 1 minute to finish up answers that people are already working on. We really appreciate your attendance. We appreciate your feedback on these types of sessions. We'll be taking the types of questions that were asked and the subjects that were asked and discussed, and identifying the topics that we need to do next or soon, as well as types of things that we should be sending out via our listservs or other announcements that we are making. So we do take all of this information into account. So I'm going to give everybody another minute here to finish up answers they were already working on, and we will then close out. And thank you all again for attending.